Dr. Sachin George, MBBS, DA, DNB, and MNMS. He is a senior consultant and head, Department of Anesthesiology and Perioperative Medicine in Rajgiri Hospital, Aluva. He has been a consultant in Rajgiri Hospital, Aluva. He has been a consultant in Lourdes Hospital, Cochin. She has been a senior resident in Wenlock Hospital, Mangalore, senior resident in Kasturba Medical College, Mangalore, and he was also a tutor in Government Medical College, Cochin. His interests include quality aspects in anesthesia practice, operation theatre efficiency improvement practices, obstetric, pediatric and regional anesthesia, and technology in medicine. Welcome, sir.
Thank you so much for that introduction. And thank you so much for inviting me to be with this conference, be with you all. Thank you organizers for the immaculate hospitality you provided since I came to Mysore. I bring greetings from the beautiful city of Kochi to the beautiful city of Mysore, and from a hospital where I work, that is Rajgiri Hospital in Aluva, that is located in the suburbs of Kochi. This, I understand, most of the audience are postgraduate residents. So I have been asked to cover recent advances in neuromuscular monitoring. So straight away jumping to neuromuscular monitoring to a group of postgraduates without mentioning something about the basics, which I found as a very dry and boring topic when I was a PG resident. Half of the time I didn't pick up what I had to pick up to understand the basics when I was a postgraduate student. So I would rather spend some time with the basics and then jump to the recent advances. I hope the organizers won't mind with that. Now, what constitutes a residual neuromuscular blocker? We monitor neuromuscular blockade to prevent a residual neuromuscular blockade. That is one of the most one big nightmare for any anesthetist. So, inadequate neuromuscular recovery as measured by objective neuromuscular block. We'll come to objective and subjective patterns later. And inadequate trainer for recovery of less than 0.9, a TOF ratio of 0.9, leads to adverse outcome. Now, a large study done in 2003 had somewhat changed the concepts of neuromuscular blockade and how when we define the blockade when it is reversed. Based on the study, and from 2003 onwards, we have these points very clearly meted out. The TOF ratios less than 0.7 and 0.9 were observed in about 16 and 45% of the patients respectively. So, of these 239 patients studied, these patients were tested 2 hours or more after the administration of muscle relaxation. So, it was surprising to notice 10% of these patients had a TOF ratio less than 0.7 and 37% had a TOF ratio less than 0.9. That is after 2 hours of neuromuscular blockade administration. And clinical tests, which we normally do before extubation, like head lift, tongue depressor test, and manual assessment of fade, shows poor sensitivity to detect residual neuromuscular blockade. Again, in another large study published in 2010, they understood impaired inspiratory flow and partial airway obstruction were seen at a TOF of less than 0.8. So this was largely responsible for the post-operative complication with inadequate airway protection. So based on this, the recommendation has changed to a TOF ratio of 0.9 that is now considered as residual neuromuscular blockade. Now, having defined the recovery, we have to keep in mind a few things. One is there is large variability between patients. So some patients display obvious muscle weakness despite a TOF ratio of more than 0.9. We have seen complete recovery, clinical recovery of muscle strength in other set of patients with a TOF of less than 0.9. And distressing symptoms in a awake patient can be observed even at subtle level of neuromuscular blockade with TOF of more than 0.9. On practical level, what we normally do is we assume the patient has adequate muscle functionality when the patient breathes normally, when he is able to maintain an patent airway, and patient can retain protective airway reflex. Now, adverse effect of neuromuscular blockade that I don't have to elaborate, because a practicing anesthesiologist and PG residents would have seen at least 1 or 2 episodes of this happening in their theaters. It is not a very rarity. So the sum effect of all the physiological changes are you have weakness of respiratory muscles, the laryngeal muscles, the upper airway muscles. The effect of all these are increased risk of respiration, increased risk of airway obstruction, risk of aspiration, impaired cough, so they can't take out the secretions effectively, leading to impaired ventilation and oxygenation. And the clinical implication definitely may end up with prolonged ventilatory weaning and postoperative pulmonary complications like ventilator-associated pneumonias and all those things. Now, that makes it very important for us to assess the neuromuscular blockade, assess the recovery from neuromuscular blockade, and make a definitive plan for your patients when they come out of neuromuscular blockade. So, how do we evaluate the adequacy of blockade and reversal? So, clinical criteria, as I mentioned before, we usually look for these 4 things: whether the patient can maintain an adequate head lift, adequate jaw clench, grip strength, and tidal volume. Now, these are unreliable predictors of neuromuscular recovery. We do it because most of our centers are not equipped with other modalities of neuromuscular blockade monitoring. When we don't have any other things, we are justified in using this. What I want to impress upon you as this lecture goes on is exactly this. So, it is possible to maintain a 5-second head lift. That is when you normally plan for an extubation. But if you see a TOF, there may be instances where the TOF is less than 0.5. So, and you have to be very careful. None of these tests are not specific for respiratory function. So, we assume that if the patient has these kind of muscle power recovery, we assume that these patients can very well maintain the airway and have adequate respiratory function as well. Now, we'll come to the measurement proper. We have subjective or qualitative measurement, and we have the objective or the quantitative measurement. Now, we'll deal about the subjective or the qualitative measurements first. So in 1958, as you all know, Christie and Churchill Davidson described the use of nerve stimulator, but again, the popularity of this equipment came into forefront only when Ali and colleagues discovered the trainer force stimulation. So, the degree of neuromuscular blockade can be assessed by applying a supramaximal stimulus to a peripheral nerve and then measuring the associated muscle response. The nerve that is chosen has to fulfill certain criteria. First, it must have a major motor element. Second, it must be very close to the skin because the stimulation can be done only percutaneously. The third, the contraction of the muscle groove which supplies the nerve must be visible to the person who is conducting the test. So, in order to stimulate a nerve, an electric current will have to be applied. The current is usually applied transcutaneously via an ECG electrode, as you all know. So, the nerve that is chosen may have many motor fibers. So, for an effective contraction, all these fibers has to be stimulated to produce a maximum muscle contraction. So, generating an action potential in all these nerve fibers will require a current that is sufficient in magnitude and duration. Now, this is very, very important. Okay. Now, most nerve stimulators generally generate a current of 0.1 to 0.3 milliseconds, which is more than adequate. So, this current that generates a response through all nerve fibers and cause a maximal muscle contraction is termed as a maximal stimulus. Now, what we apply is 25% over and above this maximal stimulus, that is called as supramaximal stimulus. Now, we'll come to patterns of stimulation, your stimulation of patterns in your objective stimulation, objective observation. So, first, most easily discoverable, the most easily done is a single twitch stimulation. This you have been studying from your physiology days. So, a single square wave of supramaximal stimulus, keep in mind what supramaximal stimulus is. When it is applied to a peripheral nerve for a period of about 0.2 millisecond at a regular interval, a response is evoked and this response is observed. So, the twitch response will only be depressed when a neuromuscular agent occupies 75% of the postsynaptic nicotinic receptor, so that the action potential will not pass. The twitch depression will need to be more than 90% in order to provide good condition for abdominal surgery. Now, this is very easy. Why is this not popular? Will come later in the lecture. So, the timing of the single twitch is very important here. So, the most useful time to apply a single twitch is at the onset of neuromuscular blockade. So, using a single twitch at 1 Hz, it is possible to establish the level at which supramaximal stimulus is obtained. Now, if you see the picture, the diagram given on the side, you can see the onset of neuromuscular blockade can be observed using a single twitch and one twitch, that is single twitch at 0.1 Hz. 0.1 Hz means one twitch every 10 seconds. So, the onset and recovery from depolarizing and non-depolarizing block monitored using single twitches have a similar pattern, differing only in the time scale. That is evidently shown in the line diagram given. So, the major limitation of this technique is the need to measure a control twitch before administering the neuromuscular blocking agent. So, which means you have to give a shock to the patient before the induction, before the neuromuscular agent is administered. And single twitches are also used in post-tetanic count, but this instance the control twitch is not required. We'll come to that later. Now, the most commonly used modality, the trainer for stimulation, which I mentioned before, was developed by Ali and colleagues. This was developed in an attempt to provide a clinical tool to measure the neuromuscular blockade in an anesthetized patient. So, the principle here is to produce a pattern of stimulation that did not require the comparison of evoked potential to a controlled response obtained before administration of neuromuscular blocking agent. So, the pattern involved stimulation of ulnar nerve with a trainer for supramaximal twitch stimuli with a frequency of 2 Hz, that is 4 stimuli separated by 0.5 seconds. The trainer 4 was then repeated every 10 seconds, that is a frequency of 0.1 Hz, as well as enabling the observer to compare the T1, that is the first twitch, to T0, that was the control. Again, comparison of T4 or the fourth twitch to T1, this can also be done. This is known as the TOF ratio, which we mentioned before. So, when a non-depolarizing agent was given, a typical pattern is obtained. There is a reduction in amplitude of the evoked responses with T4, that is a fourth twitch getting affected first, then the T3 followed by T2 and then finally T1. So, decrement happens, as the block becomes more intense, T4 disappears first, followed by T3, T2 and finally T1. When there is reversal, T1 reappears first, followed by T2, T3 and T4. This again you would have seen in your operation theatres when TOF monitors are used. So, keep in mind that during the onset, T4 disappears at about 75% depression, T3 depression of T1, T3 at 80 to 85% depression of T1, and T2 at 90% depression. So, all these are compared with T1 for prediction. So, during a partial non-depolarizing block, the number of twitches correlates with the number of neuromuscular block. the twitch suppression 90% would equate to a TOF count or 1 or less. So reversal can be safely achieved when TOF count is 3 or greater than 3. So one of the most useful clinical application of TOF ratio is monitoring recovery from neuromuscular blockade. This is where I mentioned before a TOF ratio of 0.9 should be achieved before tracheal extubation. Now TOF pattern is less useful in monitoring depolarizing block. During a depolarizing block, each of the 4 twitches are equally decreased in size and there is no fade like I mentioned before. This same pattern is also observed during recovery. Sometimes a block produced by a depolarizing drug which develops some sort of a non-depolarizing block. So with TOF monitoring in this pattern, that is a phase 2 block, fade is observed. So this is the pattern of response. In normal response, when no drugs are present, you get twitches, 4 twitches at the same intensity. In a depolarizing block, you observe the fade phenomena. In a non-depolarizing block, in a depolarizing block, you have phase 1 blockade, which mimics as if there are no blocks. Only thing, the amplitude is less. In phase 2, you have fade with the TOF less than 0.3. Now there is another modality called tetanic stimulation. So here a high frequency of 50 to 200 hertz current is used with a supramaximal stimulus for a set time. Normally for 5 seconds this current is given. In a healthy skeletal muscle, this stimulus causes a tetanic contraction. Now if a non-depolarizing muscular blockade is used, this block will not cause a tetanic stimulation, but it will show signs of fade because the stimulated muscle will be unable to maintain a sustained muscle contraction. Now, this fade is studied to detect the degree of neuromuscular blockade. So the pattern is stimulation is much more sensitive than TOF and can be used in postoperative period, but tetanic stimulation, since it is extremely painful, you have to use it with caution. Now this is what I've mentioned before. You will come to post-tetanic count. So in a profound non-depolarizing neuromuscular blockade, there may be no response to TOF or a single twitch stimulation. So in such circumstances, a post-tetanic count may be useful. So post-tetanic count is nothing much. If a 5-second tetanic stimulus at 50 hertz is given, after no twitch response, followed by 3 seconds, further single twitches at 1 hertz is given, there may be a response to a single twitch stimulation. This pattern will not be seen during very profound block. So this response is only seen in early stages of recovery. So this is known as post-tetanic facilitation. On completion of tetanic stimulus, acetylcholine synthesis happens and mobilization is continued for a short period of time. So as a result, there is increased immediately available store of acetylcholine, which causes an enhanced response to the subsequent single twitch stimulation. So the number of post-tetanic twitch is an indication of when the first twitch of TOF will reappear. For instance, if the first twitch of TOF generally returns with a PTC of 9 when using atracurium of vecuronium, you can have a correlation. So main use of post-tetanic count is when a profound neuromuscular blockade is required, that is during ophthal surgeries. So this happens by mobilizing. You have to keep in mind that this happens by mobilizing acetylcholine. This might affect the neuromuscular junction of a significant for a stimulated nerve for a significant amount of time. So 2 post-tetanic count administered in quick succession, the degree of neuromuscular blockade will be underestimated. So it is recommended that no stimulus should be applied for a period of less than 6 minutes. So this is the pattern what you normally see in tetanic stimulation and post-tetanic count. The next is double burst stimulation. Even small degrees of neuromuscular blockade clinically can be observed in this a pictorial representation. Now, objective and quantitative measurement. So this is where I wanted to comment on. There are different types of objective monitors. The electromyography, there are two types that is mostly used now, the tetrasense and the twitch view, where more advanced modalities of these things can be monitored. Acceleromyography, where adductor pollis muscle skin surface electrodes are placed over at ulnar nerve, and accelerometer that is taking into account the acceleration of the muscle when a twitch is applied. This is the equipment. And kinemyography, where the electrical signal generated from distortion of the thumb and the index finger by using a piezoelectric crystal is used. This is the acceleromogram. And mechanomyography, which is not used, this is considered as a gold standard, but is not used because of bulky and expense of the equipment. So mechanomyography uses force of contraction, accelerometry uses the acceleration of muscle contraction, electromyography uses the compound action potential, and kinemyography uses the bend with the piezoelectric crystal. Now, qualitative or quantitative. Now, a study which evaluated 40 years of neuromuscular blockade clearly mentioned that complications have developed after a qualitative or the objective measurement, and in real world scenario there are again ambiguities in usage. So in 2018 there was a consensus statement from American Society of Anesthesiologists which state that objective monitoring is the only method that assures satisfactory recovery of neuromuscular blockade. Almost at the same time, French Society came out with a study which all mentioned in the same way, and the recommendations from 2021 American to 2023 American and European Society guidelines are mentioned. I just brush up with us because of paucity of time. So when neuromuscular blockade drugs are administered, solely depending on clinical criteria is not advised. Quantitative monitoring is recommended over qualitative. When quantitative is measured, TOF ratio of greater than or equal to 0.9 is recommended, and adductor pollis muscle is the ideal muscle that has to be used. Sugammadex is preferred over neostigmine for reversing deep, moderate and shallow levels when you are using rocuronium or vecuronium. So neostigmine can be used in minimal neuromuscular blockade. So when cisatracurium is used, monitoring is suggested, and in absence of quantitative monitoring, at least 10 minutes should elapse from antagonism to extubation when cisatracurium or atracurium is used when you don't have sugammadex. A few good reads on this topic. Thank you.